Hey, hi everyone. I'm Talia. I see actually all the names that I see are familiar, so you know who I am. I'm the content community manager. It's very nice to see that you are here again. This is our first ever Ktalk. We're super excited. We intend on doing more of these events. They are meant to be more intimate chats on topics related to COVID and beyond. So today to kickstart it, we are doing a Ktalk on data privacy. And we have expert and privacy attorney here, Jay Ward. We're super pumped to have him.
And for those of you that don't know me, I'm Leslie Krumholtz. I'm the CEO and co-founder of Hugo Health and Kindred.
I'm a privacy lawyer and a data strategist based out of the University of Oxford. I've known Leslie and Hugo for a long time now. So this is one of many collaborations for me, and very happy to be talking with you here today about data privacy and the intersection of the two.
Great. And just so all of you know as well, Jay has been really helpful to us as an advisor and consultant for some of the work that we're doing with data on Hugo and Kindred. He's well aware of the work that we have and has really deep knowledge in this space. So Jay, why don't you kick us off?
I like to say I'm a recovering litigator. I spent many years in courtrooms, still do some of that work. But about 7 or 8 years ago, I started to really focus on data and privacy as the largest part of my practice. And I was in the United States. I'm now in Oxford, at the Oxford Internet Institute. And I'm really interested in the intersection of privacy and advances in technology and the law, and how those things inform one another, push one another, and create barriers to one another. And for me, the work that I've done with Hugo and the work that I've done in the health tech space more generally is really about identifying ways that individuals can have more control, more autonomy, more freedom to use their own health data, and helping to frame conversations about these issues with a different concept in mind, which is to say that rather than thinking about data as property, the way we'd think of our cars or our cell phones, to think about data as an extension of ourselves, as a manifestation of ourselves. And when health data is concerned, it's both an extremely sensitive manifestation of ourselves, and one that can be extremely powerful and helpful to us, both as a methodology and a tool for improving health outcomes and for forging community and for advocacy. And I think some of the things that we'll talk about today go to those points. And just more broadly, it's anytime there's a chance to talk about the way we think about health data and health tech, I think it's an opportunity worth taking.
Great. So do you want to dive in? I think the way we formatted this is, first of all, please feel free to drop questions in the QA or in the chat, as we always do. That's no different. The Ktalk's no different than our cafe. So please feel free to do that, and we'll be really happy to answer those questions and hopefully have a dialogue. I think the way we're going to do this is Jay's going to kick us off, and he's going to kind of lay the groundwork for all of you. We thought it was important for you to sort of understand kind of the trajectory of legislation and the push that, in the US, the push towards patient access to their data and how that's happened kind of over the decades. And then I'm going to share some slides on Hugo and sort of how we're looking at that for people. So if that makes sense, we can just sort of move forward, I think.
Yeah, happy to.
Great.
So whenever I talk about health data, or the nature of the movement of health data in the US, it all come back to HIPAA. And I like to say that there's two HIPAAs. There's the Health Insurance Portability and Accountability Act of 1996, HIPAA, which is the law that governs the protection of your health information, and as it relates to the payment for and treatment of conditions. And then there's HIPPA, which is the thing that people talk about on Facebook or Twitter, which doesn't exist. But you can use it to say whatever you want. Like, well, I can't tell you which brand of toothpaste I bought because HIPAA. You can't ask me how I'm feeling today because HIPAA, and that's the one with 2 P's. So you can always tell which is the real one because one has 2 P's and one has 2 A's. That's that may seem like an unbelievably smarmy way to start off, and I'm just an unbelievably smarmy guy. But the reality is, I say that for a reason, and it's that people want there to be an enormous amount of protection for their health information because we all feel a deep sense of proprietary need for control over our health information. It's deeply personal, it's private. Obviously, there's a load of emotions that are wrapped up in our health and sharing information about our health. Conversations one-on-one about our health are sensitive, let alone sharing that information with others. So this sort of yearning for HIPAA, this broad, vast swathe of protections for our health data is natural. That's what we want, but that's not what the law says. The law is much more limited. And HIPAA with 2 A's, the law that's actually on the books, is really just about controlling who can have access to information generated. It's called PHI, personal health information, generated when you get treatment or when you try to pay for your treatment. So who gets to see that? Healthcare providers, insurance companies, and anyone who does business with them to either provide you with healthcare, so think like Quest Diagnostics, for instance, or who is responsible for securing payment. So insurance companies, debt collection agencies, sometimes, occasionally your employer, and that's it. It's a very limited universe of people. And this framework in 1996 reflected the development technologically of centralized records, but almost all of those records were paper records. So when HIPAA was written, most hospitals in the country did have some computerized technology, but they had decades worth of files that were literally files, that had the color-coded WAR, the three letters, so that they could identify your information. And it's interesting because HIPAA comes right at the end of that era, the end of the paper era. Almost immediately thereafter, scanned electronic documents or electronic health records, which is what we call EHR, really began to emerge. Sometimes they're called EMR, electronic medical records. And so just a couple of years after HIPAA, it was obvious there would need to be a change because now not only were there computerized records everywhere and mass movements of data, but the internet had started to become, a real thing, and people recognized, even at the incipient stage, there was going to be a need for some controls over how this data was moving. So interestingly enough, they were pretty flexible, pretty forward-looking with HIPAA and the way that they interpreted it. So the Department of Health and Human Services, which oversees HIPAA, they issued 2 rules. One was called the security rule, and it was called the privacy rule. And the privacy rule, I don't know if any of you have ever worked in HR, but the privacy rule is the reason why you have to have a placard near the fax machine. And you can only move certain papers from some rooms to other rooms. It instituted very substantial safeguards on the movement of data. And it was one of the single costliest regulation the medical industry in the United States ever saw. Not because it made the cost of treatment go up, but because all of a sudden you needed to have specialists hired to just manage the movement of information. And that wasn't the intention, but that is what happened. And so the way that healthcare providers responded to this was they built brick walls around the data. All of the healthcare data that they had, all of the information, all of your information, all of my information, was essentially locked into a silo, and it could only be accessed by a select group of people, and then for only select purposes. So it was sort of like, an ancient Greek mystery religion. You had to put on the special robes and go in and pull them out. No one was allowed to know what you were doing. And it did increase the privacy of many people's data, but the utility of the data was basically gone. You could look at a chart, get information just from your doctor, but if you've ever switched doctors, getting the records from one doctor to another in this era was extremely complicated. And people started to recognize that this was a problem. So all through the aughts, all through the 2000 to 2010, there was pressure that built to get this to be changed. And in the last decade, those changes came into effect. So a couple of things happened to really change the way we thought about how health data could move around. So one of the things that happened was something called the High Tech Act. So that's the Health Information Technology and for Economic and Clinical Health Act, High Tech, because Congress loves initialisms for some reason. The High Tech Act, despite being wordy to say, was actually pretty forward-looking. And what it did was it examined the problems that happened with the privacy and the security rule and shifted the focus to say, okay, we're protecting data, but we're making it impossible for individuals to use it. Where, you get the situation where you'd go to the doctor and say, okay, I want my records. I just want a copy of my records. You can't have that. HIPAA. I can't give you those records. But it's literally my body. I would like my health information, please. And they'd be like, I'm sorry, there's nothing I can do for you. And the absurdity of that prompted Congress to act. And so High Tech said, look, individuals should have the right to control their health data and to use their health data in the way that they see fit. So what we want to see happen is healthcare providers should adapt and adopt technology that would allow them to use and make usable healthcare data. But then as a corollary, we're going to open this data up a little bit, but we're also going to make serious penalties if you fail to use that properly. So there was a balancing act. We saw this again in the 21st Century Cures Act, and this was in 2016. 21st Century Cures Act is this really interesting effort where Congress says, look, yes, the high tech and the rules developed off of high tech say that you should be allowed to use your data, but it's not clear enough. So here's what we're going to say. All health data generated by an individual belongs to that individual. Whatever they do with that data, they can choose to do whatever they want with that data. It belongs to them. Healthcare providers and business associates of healthcare providers are still covered by HIPAA. There's very specific rules that govern what they can do with that data. But anyone else who wants to, any individual who wants to have access to their health information should be able to do so. And in fact, healthcare providers need to adopt technological tools that allow the movement of healthcare data to happen. You need to basically unlock the movability of the data. So that's 2016. We have a couple of years of them trying to put that into place. The Department of Health and Human Services says, okay, let's think about how we want to do this. And then COVID hits. And the immediate recognition of, boy, it really would be nice if we had free mobility of health data so that we can understand what we're doing and, maybe give people a chance to monitor their own health or, pursue better solutions, prompted some pretty rapid action. And so where we are now is this really interesting place where the original rules of HIPAA all still apply, and the safeguard rule and the privacy rule still apply. And your doctor can't sell your information to anyone else. But we now have a lot more rights in using our data. Technically, we can ask for everything from every healthcare provider we have. So give me all of my data. Practically, that doesn't really happen, right? So where we are is the law allows it and people want it, but the technology is behind, which is a very rare thing. Usually it's the other way around. Usually the law and people's understanding lags behind what technology can do. But now the movement of personal health data and the movement of these electronic health records is slowly but surely becoming, it's becoming more feasible. And it's partially because of companies like Hugo, which sort of sit at this intersection of the movement of like a secure channel for the movement of this healthcare data, but also making it usable, presenting it in a format that can be worthwhile and helpful to individuals. And that's the key. That's the whole point of the 21st Century Cures Act. That's the whole point of high tech, is not just, make it available. If you have a key to a door and the door unlocks, that's great. But if the door weighs 3 tons and you can't open it, what good was your key? So it's the creation of both the access and the usability that really matters. And that's where the next, I think, 5 to 10 years in health tech are going to be. It's going to be about identifying ways to make the data that you have valuable to you, and valuable in ways that we don't normally think about health data being valuable. Because when a doctor or a healthcare provider reviews your files, they make an analysis and they come to a conclusion. And sometimes you bring the same data to another healthcare provider and they reach a different conclusion. That's fine. That's a known value in the healthcare data. And then the insurance company has lots of information for actuarial tables, for calculations. That's a known value. The new value, the thing that's really being unlocked now, is the autonomy and the decision-making capability that individuals will have when they can ingest and understand the data that they have. And that's one of the, that I think is going to be the real cutting edge of health tech. That's going to be the tip of the spear. Finding the ways to bring in and interpret and make understandable all of the information that's available to an individual patient about their own health, and unlocking ways for them to have better adherence to a treatment protocol, or insights from a community, or just community full stop. And as we unlock the potential that the data has by putting it to these new uses, I think we'll derive a lot more economic and non-economic value from it. So this arc is really interesting. We started out with paper rules, rules for paper, protection of paper files. And now we're at, how can I download my entire medical history to my device and then compare it to an anonymized data set of others to understand where I fall in metrics and maybe ways to, to pursue what's best for me. It's a fascinating time. And it's I think a really important time. And hopefully thinking about these issues and talking about these issues and putting privacy and a human-centered approach at the forefront, that's crucial, because in 2016 people maybe had some ideas about this, but in 2011, 2003, 1996, forget it. There were no opportunities to talk about this. So the more we have these conversations, the more informed we are, the more we develop community awareness of them, the better. It's really important to do what we're doing. So that's kind of the 10th and maybe 5,000 foot level explainer on the regulations around the privacy and the utility of healthcare data in the US.
That's great. That was very helpful. Thank you. I think it was a nice, clear overview of sort of the, as you said, the trajectory of how the regulations are going. And for Hugo, we started, my husband Harlan and I started the company back in 2015, really with this sort of anticipation that this is going to happen, and that it had to be done the right way. In other words, privacy was going to have to be key, especially as Jay, you referred to, it's health data, and, of all data that's out there, it is a representation of ourselves. And so, we had this idea that if we were going to do this, it was really going to be honoring that for people. So, we take the approach that we don't own people's data. We're really fiduciaries of that data. And that when people collect their data on Hugo, it is really under their control, and that nothing would ever move unless they gave permission. Now, it's the exciting piece is what you just ended this with, which is, the possibilities of what people can do with that data. And that's really what we hope to be able to provide people once they have it. So that is a sort of a good lead into where we are. I'm going to share my screen. I'm going to just, our tagline for Hugo is health data when you need it. And that's really the idea that, for people, that you should be able to have your health data when you need it. American patients have seen an average of 18.7 different doctors during their lives. And the average patient's health is dependent upon information that resides in approximately 19 different locations. Now, that's a large number of doctors and providers that are scattered about the US that, an average number of people see. And as a result of that, there are vast amounts of data that are generated globally. And this is, this was mind-blowing to me, actually, that in 2022, there was 97 zettabytes of data. This is global. This is not just health data. This is all data. And then in 2023, they're expecting it to be 120 zettabytes. 1 zettabyte or zettabyte is 1 trillion gigabytes. So you can just imagine the amount of data that we as a society are generating as we go through our daily lives. 30% of all that data, however, is healthcare data. But these are all the different forms of data that we generate as people. And I think of us all as patients, because one way or another, we do interact with the healthcare system. There's clinical trial data and registry data. There's data that we create from our own clinicians. We create, data from our pharmacy and from labs. We have, data that's created from digital health companies and apps that we join. There's tons of financial data. As of late, obviously, this patient reported, meaning data that we report via diaries that we have, or generated via wearable devices that we are wearing, and then payer data. So all that data actually originates from many unconnected sources. And it's not only data from, as Jay referred to, our electronic health record, but now that's also including those paper records that still exist out there. There's data from legacy systems. High tech came into effect. Actually, what it did was it was the money that gave all of our providers the ability to digitize records. So before that, it really was all paper records. And it was the government that said, if you digitize your records, then we will reimburse you. The portal, the patient portal, the other interesting thing about that is you think the patient portal that we're all now familiar with from our providers, EHR, we thought that would be built for us. It actually wasn't. In the same time with high tech, one of the other things that came up was the government realized that, great, we're giving all of these data holders the money to digitize their records, but we need them to be made available to people. And so they had something called meaningful use that came up. And meaningful use too was something they had to achieve in order to get paid. And that was that a person had to have the ability to view their data, download their data, and transmit their data, hence the patient portal. That was why the patient portal actually was created, and it was never really built for people. It was built so that providers could get paid by the government. And so when they first came out, they were not very user-friendly. I have to say, again, as I've seen this over the last 8 years, they've become much more usable. If you have a MyChart, for instance, from Epic, or Cerner is another big EHR system, their portals have become more usable, but they were not developed for people. And now there are emerging other data sources. So there's, wearable device and sensor data and self-reported data. There's data now from virtual and remote care visits that we have, all the digital health solutions. And what's happened is that data actually now is put into 2 buckets. It's either called structured data, which is the data that's electronic, that's quantitative. So in your medical record, those are things like lab results, medications, certain codes that doctors use, prescriptions, vital signs, things that are quantifiable. So you can imagine the other side of the bucket is the unstructured data. And that's all the qualitative data. And there's so much of that still out there that has not been made structured yet. So there's images, all your images and graphics, your radiology reports, any notes that doctors put in your record, discharge summaries. Those are all, as you're familiar with the idea of a PDF, right? They print it out to you, and the only way that those can actually become structured is with the use of natural language processing. You might have heard of that, or AI, basically. And so that they are able to sort of start using that data on the unstructured side. And that's where we are right now. And in terms of the data. Now, the data itself is also pretty messy. So you can imagine that data is coming in all these different formats. We still have not really solve that problem. And so you've got data coming in from a Fitbit that's in a different format than the data that's coming in from a lab or from your provider. So it's still, I've said this before, that we're pioneers. We are, and you are part of something that, as Jay said, another decade will be totally different. If you can think about, sort of the fintech world and how far that's come, we're sort of on the cusp of that now. And so as a result, your health data does reside in lots of disconnected systems all over. And as a result, many of you as patients may have already experienced this. It's also sometimes incomplete now, it's inaccurate, it can be delayed. The the doctors and providers themselves have come up with all kinds of workarounds for that. Really, everyone in the ecosystem has figured out a way to benefit from this data, except for the patient. So it's been built to meet the needs of everyone but the patient. And quite honestly, whether we like it or not, our health data is a proprietary asset of these systems. And so we actually do hold the single key to unlocking health information because, as Jay talked about, we have the legal right to obtain it. So when you have, when you've seen providers at 5 different places, and one of them uses an Epic system, an electronic health record, where you might see your MyChart, somebody else uses an Allscripts, a medical record system, and you may have a patient portal called Follow My Health. Epic and Allscripts are 2 big companies, and they don't talk to each other. So there has to be a way for that data to come together. And that's really what Hugo does, is it's leveraging your right as an individual to pull in your data from all those different places across the ecosystem that are not interoperable, is the other word, that don't talk to each other. But you have the ability to become the key to interoperability, to actually make that data talk to each other. And so this is really, what Jay talked about. And just, I'm not going to repeat what he did, but you can see, in the 80s, we had a paper culture. It was the HIPAA privacy rule that came out. Then high tech came along, and that, there was the issue of the EMRs not being able to communicate, even though they finally came about and digitized records. There was not interoperability. Then 21st Century Cures came along. It's trying to solve these problems. And there's lots of things also happening in the background. So, market forces in emerging tech in between 2012 and 2022 are really sort of pushing us in this direction, right? So we know patients have become more activated about this. Wearables have come on the market. People adopted smartphones back then. There's, the whole idea of the Internet of Things that just in. The open notes movement was something that came about because doctors were not releasing your notes to your portal. So you have a right to your notes, but doctors were not releasing them. There was a fear that, like, oh my goodness, if I release those notes, I'm going to be given too many questions and it's just going to become too cumbersome. I can't, or, what have I written in those notes? But now the Open Notes movement is an organization that came out of Boston that has gone about and very successfully taught hospital systems why it's important to have notes released. And actually, with 21st Century Cures, notes have to actually be released at this point. And then came the pandemic. And what we saw with the pandemic is this sort of emerging digital culture. Now, those of you, especially those of you that, that have, suffered as a result of the pandemic, you've probably had telehealth visits. As a result of those telehealth visits, you're more comfortable with digital technology. You had to create a patient portal for yourself in a lot of cases. All sorts of things have helped to sort of create much more of a mindset for digital, for a digital culture. And now with the final rule that just came out in October, it really is saying, these big companies cannot data block, and they have to make that data available. So here's Hugo. So what have we done? We're saying that we have a fundamentally different approach to data collection. We've built our technology on direct patient permission, that through that we can unlock the power of health data and create faster, more affordable, more accessible solutions. So this is how Hugo works. We leverage your right to get your electronic health record data, and to continually scroll that over time. So on the left side are those same icons that I had above. So those are sources of places where you have data. When you use your credentials to connect to your patient portal, you're giving us permission to pull that into Hugo's very secure cloud-based private account. And then only again with your permission does it get exported. So for those of you that perhaps are participating in the Listen study, that's an example of an informed consent that you sign to say, yes, I will allow my data to go to the research study that I am giving permission for, to use it for the first purposes that they have gotten approval from the, from the internal review board themselves for that study. On the back end of Hugo, we have dashboards that allow those researchers to monitor your participation in the study, and your data also will go into a database. It could be used, if you gave us permission, for an application that you want the data to go to. And again, for people that are in studies. But really what I want to emphasize is that it is with only your explicit permission. And so aside from Kindred, which you are mostly all familiar with, we have provided a platform for research to use Hugo's technology to connect people to their data for research studies, and they're funded by the CDC, the FDA, the NIH, and some of those are studies that happen on site. And so the stars on this map indicate where there are actually sites going on. There is a study that started in 2020, but funded by the CDC called the INSPIRE study. That's a COVID study. And then siteless studies, decentralized studies, and that's what the LISTEN study is, right? You don't have to show up anywhere to participate. It happens virtually. And so we have users across the US that are part of Kindred or in some studies that we are a part of. So how does Hugo handle your health data? It's via the API that we've talked about. That is the interface that allows computer programs to talk to each other, to give information. It allows Hugo to communicate with your patient portals. They are what 21st Century Cures is mandating be made available to people so that this data can move. Information is always encrypted when it's sent. So if it's intercepted, it's meaningless to any bad actor. So just a couple of terms that, just to familiarize yourself a little bit, but 4 main terms are: there's a server, and that's all the software that's behind the scenes that processes our requests and pulls the data back and forth. A client is a user like yourself, or a website or software that's making the request for the data. The request is what you're ordering for resources from the server, and a response is what's returned. And so we can do this sort of a metaphor to imagine dining at a restaurant, right? How do you order food? So if you look at the menu, you decide what you want to eat, then you tell the waiter what you'd like to eat. Then the waiter takes the order back to the kitchen, and then the kitchen staff makes you the meal and returns it. So if you do that, thinking about this way, you are the client. The waiter is the API, because the waiter is the one that's going back and forth, taking your order and bringing back the food. Your order is the request, and your meal arriving to the table is the response. So it's just sort of a quick way to sort of give you a sense of how an API actually works. And that's how Hugo is getting your data from your portals and from your wearables and wherever else you're connecting. This is how it works. So at the top here, I want to connect my portal X, which is what we have, right? That's the user to Hugo. Then Hugo says this user wants to connect us to portal X, to the EHR. And then the EHR is going back, please authorize the connection by logging into portal X. The EHR is telling the user. The user says, here's my authorization, and putting in its credentials. And then the EHR is saying, here's a token for that user at that portal. And then Hugo uses that token to access your health information. Again, we don't store anything. Everything is put into the token. And that's all this new technology that has been evolving for, probably a decade or so. And then here's just sort of an example of how that works. So Hugo Connect is our technology that we have embedded into Kindred, right? So when you go onto your Kindred homepage, you see, make your data connections. And that is that process that I just showed you. We call it Hugo Connect, but it's really that process of data collection through the API. We, as I said, when it comes to privacy and security, only moves with explicit permission. We make sure that your data are encrypted always when they're moving and when they're stored. Your tokens and your login information are stored in physically separate databases, so they can't be connected in any way. We're a member of the Karen Alliance. It's made up of a number of organizations across the healthcare ecosystem that sort of set the standards for how patient data privacy should exist. And again, we don't act we don't own your data. We only act as a fiduciary of that data. So I think that is all I have, except that empowering people with health information will be the culture shift that will transform medicine. And all of you are really important pieces to that. And so one other point I want to make is so when if you haven't already tried to connect your health data in Hugo Connect, and sometimes it says needs attention, or it doesn't seem to be working, or we have to recontact you because it's not working. That is because we are as a society at a place where this is still evolving. It will get better. I say, as Jay says, I say 5 years from now, you're going to look back at this time and say, what? We actually had passwords? Really? So it is an area and a space that's evolving very quickly. I appreciate, all of you who have the patience and the persistence to continue to work with us to make that possible, because at the end of the day, you having your data will hopefully, benefit you, and by participating in research, benefit society, and eventually, as we talked about, provide other kinds of value for you.
We have one question. So a patient can have all their records from every source sent directly to Hugo for free to use as wanted at any time. And then a follow-up question, is there anything to be done about all the errors we know are there?
Yeah, so those are all really good questions. So we are working on our end to connect to all of those data sources. There are what we call kind of the last mile. So there are primary care doctors who have either not adopted electronic health records yet, they're still using paper records, or they've got sort of these kind of, we call them homegrown EHR systems where it's pretty hard to connect to them at this point. But if you notice in the Hugo Connect, where you can connect your data, we added the upload feature. And that is so that we would like you to be able to, and we'll help you do this, download your record from your patient portal and upload it. So it's the same thing, although it doesn't continue to update because it's one-time load, but it would pull all your records in one fell swoop. So if you're interested in doing that, we can help you do that. And the errors.
The idea of error correction is really important, and is one of the fundamental principles of fair data processing, is the ability to correct errors.
So HIPAA, HIPAA does not allow us to change your records. If there are errors, you need to submit a request to your provider, unfortunately, to say this is incorrect, and then they go in and update your record for you.
It's not really a question, but a comment. I don't mind sharing test results, sharing doctor notes and diagnoses, not so much. And seeking a second opinion, I'd rather they not rely on the previous doctor's notes. I want the fresh look.
Yeah, so that's a great point. And what we're working on is once you're going to be able to see your data, you will be able to say, I only want to share X, Y, and Z. So you can actually check off what you want to share and then pass that on. So that will evolve and will be available to you. There is the ability to do that. If you upload files into Hugo, there will be in the next iteration, I know they're working on that now, the ability to check those files, the ones that you've uploaded. You can check which ones you want to share and which you don't. So thank you, Nikki, for recognizing it is eye-opening. I think it's important that people understand kind of where we are as a society right now and what rights we have as patients to have control over our data. And they want to make sure that people are educated about what we're trying to do, and that you're part of this with us. So appreciate you attending, and thank you. And thank you for all you're doing as members of the community. Well, thanks so much. Really appreciate it. Have a good evening.